Changing the Narrative, a podcast on a mission to dispel viral misinformation concerning public health and public safety.
Hi, my name is Dr. Sarah Wakeman. I'm an addiction medicine doctor at Mass General Hospital and senior medical director for substance use disorder across Mass General Brigham. I'm also an associate professor of medicine at Harvard Medical School, and I'm happy to be joining you here today with my dear friend and colleague and Shiro, Maia, and I'll turn it over to her to introduce herself.
Well, I just first want to say I feel similarly, and I am Maia Szalavitz. I am the author or co-author of 8 books, most recently Undoing Drugs, which is the first history of harm reduction. And I've been writing about addiction and drug policy for many years. Currently a contributing opinion writer for the New York Times and working on a million different projects. So I'm really delighted to be here with you and to discuss this, because you and I basically thought up the idea of changing the narrative a while back, because we were all on Twitter with Leo and Zach and Tracy and all these other great people. And we were like, why is there so much bad information out there? And, we would go and be like, hey, this is wrong, and this is like a problem. And then we're like, well, maybe we should be doing this in a more systematic way, right?
Yep.
So let's talk a little bit. I think we wanted to start by talking about like how you actually define addiction, because one of the ways that the narrative about addiction tends to go wrong is because we define it wrongly. So if you can talk a little bit about like what is essential in defining addiction, and then we can, go from there.
Yeah, great. I think that's a great place to start, because there's so much misunderstanding in language and terminology, but even just what we're talking about and the sort of full spectrum of substance use. So addiction really is defined as compulsive substance use despite bad things happening to you. So we make the definition clinically, or the diagnosis clinically, based on criteria in the DSM-5 is the current one. And there's 11 criteria, and they get to sort of the core aspects of addiction, which is really losing control of your use of a substance, which can be alcohol or drugs. Compulsive use, and then use despite consequences is really a key feature of that. So continuing to use substances, not being able to stop despite bad things happening to you. So that may be problems at work, problems with your health, your mental or physical health, problems in relationships. So that kind of use despite harm. And then the fourth sort of C that we think about is craving. So that's the sort of obsessive need, urge, wish, the thought that you can't get out of your mind to use a substance. So it's really those kind of 4 C's: compulsion, loss of control, use despite consequences, and craving, that define addiction.
That is a really good way of putting it. And I want to talk about what you didn't put in that definition. A lot of people think that like the only addiction is physical addiction or physical dependence. Can you talk a little bit about why dependence is not addiction?
Yeah, this is a critical point. And I know one you and I have talked about, written about a lot, because it's probably one of the more common things people get wrong. So physical dependence, which means you sort of need a substance to feel normal. And if you stop using a substance, you'll experience withdrawal symptoms or feel physically sick, is often what people sort of think of as synonymous with addiction. And that's not true, both because you can have addiction without having physical dependence. So for example, stimulant use disorder, although people get some withdrawal symptoms, you can definitely have addiction and meet criteria for a substance use disorder without having physical dependence. And because you can have physical dependence without having addiction. And that's probably the most important thing to talk about. And where we see that, anyone who's taking benzodiazepine for a seizure disorder or for severe anxiety will have physical dependence to that medication. And if they stop taking it, they might have a seizure, they would get very ill, but they don't have addiction to that medication. It's also true for chronic pain. So if you have chronic pain and you're taking opioids and you're functioning and feeling well and it's managing your pain, if you stop suddenly, you will get sick, you have physical dependence, but you don't have addiction. And then thirdly, and really important in the area of what we're talking about with addiction, is that the most effective treatments we have for opioid use disorder actually maintain physical dependence. So those are medications like methadone and buprenorphine, where if you stop taking them suddenly, you will experience withdrawal symptoms, but people are not addicted to those medications because they're not having use despite consequences. They haven't lost control of their use. They don't have compulsive use. They're not craving the substance. So it's really those other features that are the hallmark of addiction.
Yeah, and a lot of people think, oh, people are trying to just be politically correct or something by saying dependence and addiction are different. But the thing is, if you say that they're the same thing, then cocaine isn't addictive and Prozac is, which really destroys your definition of addiction and also creates the opening for misconceptions like so-called addicted babies. If you can talk a little bit about why there cannot be an addicted baby, that would be great.
Yes. So another great point, and people have used that sort of colloquially to refer to babies that are experiencing neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, both of which are often predictable and very treatable health conditions, but are not addiction. And again, if we define addiction as use despite consequences, as loss of control of use, compulsive use, and cravings, a neonate is not sort of losing control of their use of substances. They're not having problems in their relationships because of their substance use. They're not craving a substance. They really, by definition, can't have addiction.
Well, and they don't, right. I mean, because if in order to have addiction, they would have to know what they are craving, right? They'd have to learn that the drug eases the craving. They'd have to know that what they want isn't mommy or a diaper change. They'd have to like be able to have the language and the money and the physical motor skills to be able to buy drugs. I mean, it's like, it's really quite a ridiculous concept, but I think the essence of it ends up stigmatizing these poor children. And I remember a study from the crack years where they showed this video of perfectly normal toddlers to health professionals. And they labeled some of them crack babies. And they, the other ones, they just, didn't label. And these people who are medical people, actually misconstrued the baby's behavior, and they would say things like that kid's manipulating, or they would actually sort of ascribe evil intent to completely normal toddler behavior that can be annoying, but is like hardly indicative of a character defect or whatever moral thing they want to say about it.
So critical. I mean, one, for how flawed some of the reporting and even science was at that time, especially thinking about the intersection of racism and our war on drugs and the way we have thought about drug use. And, I think cocaine and rock cocaine and the whole notion of quote unquote crack babies is a great example of how deeply intertwined racism is with our cultural perceptions of drug use and drug addiction. But also the fact that medical professionals are very susceptible to stigma and bias like any other human being. And so I think it's a reminder that it's not an issue of political correctness or semantics, that it actually changes clinical decision-making. And that's been shown even with language like substance abuse versus having a substance use disorder. That, a colleague of mine did a study where if you take highly trained clinicians, so master's or PhD level therapists, and you describe a patient as either a substance abuser or a person with a substance use disorder, the clinician's more likely to recommend a punitive treatment intervention for the person described as a substance abuser. And so language actually impacts clinical decision-making. And I think the study you cited is another example of that.
Yeah, well, I think also the abuse term is particularly problematic because it evokes in your head child abuse, sexual abuse, emotional abuse, physical abuse. It evokes a bad person in your head. Like an abuser must be a bad person. Whereas if you say misuse, or if you're talking about substance use disorder or addiction, at the very least, it is separate from these concepts of harming other people inherently in having the condition.
100%. I think, the word actually, I remember looking at this at one point, comes from an Old English word that means a willful act of misconduct. So you're literally saying this person is like willfully doing something bad. They're behaving badly, which I think closely overlaps with a lot of our societal stigma and ideology that we've all been exposed to around substance use disorder. But it's also language we wouldn't use for any other health condition. So, we would never say that a person with diabetes is a sugar abuser, or, that language would just sound bizarre for any other.
Well, also it's just weird because it's like, are you abusing the sugar? Are you abusing the poor little drug? Like it's just, and self-abuse has an entire different connotation. So it's just, I don't even know how they came up with it except for in order to induce stigma. And what I always thought was weird was like the DSM they used to have these two categories. They used to have substance abuse and substance dependence. And substance abuse was actually basically supposed to be college binge drinking. Like it was like what we would now call mild substance use disorder. And most people resolve that without any help. It can be risky, obviously, because it carries all, when you're doing these things, you carries all the risk that, you could overdose or whatever. But it is not compulsive use despite negative consequences. And then they stupidly use the term dependence to mean addiction, which left the rest of us having to like correct people and try to explain physical versus psychological. And then you get caught in, well, isn't the brain actually physical? And bleh, you get the mind-body problem right there. So, but yeah, no, it's really, I'm so glad that, and I mean, this is like 2013 that the DSM got rid of these terms. It's like amazing that people still use them and still think that like, oh, dependence is like the nicer way of saying addiction.
100%, 11 years later, and we're still in that boat. And it has ripple effects, right? Because then language like dependence, is codified in some state law. So in Massachusetts, the language around mandatory reporting is concern for emotional or physical injury for a child and physical dependence upon an addictive drug at birth, which, what does that mean? Is nicotine's an addictive drug. Babies can have withdrawal from nicotine, but we're not sort of reporting babies who are born exposed to nicotine. So I think there's confusion that then gets put into state law. And there's also ripple effects on research. And, we've written about this, but when we look at coding data, which is often how we try to understand sort of health claims and big data sets around like how common are substance use disorders and what happens when people come into health systems, doctors notoriously code things wrong because they'll code people taking opioids for chronic pain as having opioid dependence, which is actually meant to be an addiction code in the sort of way that codes are codified in claims data. But I think misunderstanding about what does this even mean then leads to all this messiness and what we're even talking about.
And that's the ICD, or International Classifications of Disease, which like is used internationally instead of the DSM for psychiatric diagnoses, but the United States uses DSM. And in this one instance, the United States is actually ahead of the world on fixing the problem. I wish I knew somebody on that ICD committee because it really is insane that they continue to use that.
Totally, and so confusing.
Yeah, yeah. I mean,
right. The other sort of language thing with substance abuser is this idea of sort of labeling a person as no different than their health condition. And so even if you take away the fact that the word abuse is problematic, there's other terms like alcoholic or addict that are also incredibly stigmatizing because you're basically saying, this person is not separate, no different from this health condition. And we would never, I would never say I'm going to see the breast cancer. It's like, that would be ridiculous. I'm going to see, Mrs. Smith, who is a mother of 3 and works as a scientist and has breast cancer, but having breast cancer doesn't define her. But that idea of kind of person first language has really taken a long time to permeate into the substance use disorder space.
Yeah, particularly that is definitely true. So I guess I want to talk about another slightly related thing here, which is the idea that if you take medications like methadone and buprenorphine, which are the only 2 treatments we have, period, that cut the death rate by 50% or more, provided you stay on them. So, but what happens when people take these medications is they're just told, oh, you're just substituting one addiction for another. And if you can speak to that a little bit, that would be great.
I think that myth and that notion and stigma about medications is probably the single most deadly thing out there because you're right, these are the only treatments we have that reduce mortality. We're in the midst of an entirely preventable overdose crisis in North America where, close to 110,000 people each year are dying from a preventable cause of death. And we have life-saving medications that would save tens of thousands, if not more, lives every single year. And yet a minority of people are getting them. And there continues to be this very negative notion that you're just sort of replacing one thing with another, that I think at its core is partly based in this misunderstanding of dependence versus addiction, but also I think just a general sort of ideology that people who are using substances are acting badly, that this is sort of a bad behavior issue and that we should make it hard on people or we should punish them and that that's what's going to help someone get better, and that anything that is perceived to sort of make it easier on someone is actually a bad thing, and that somehow medications are a negative thing rather than a life-saving intervention like for any other health condition where we would of course want to improve the likelihood that someone stays alive and stays well and stays in remission from their health condition.
Yeah, no, I mean, it's sort of part of that whole idea that like it's cheating if you take drugs for any kind of mental health condition. It's like you're supposed to do the hard work of recovery, and or like, oh my God, you might take Ozempic, you're supposed to do the hard work of diet and exercise. And it's like, no, like what the existence of these substances and treatments is telling us is that this is not about you're a bad person. And it's not about you don't have enough willpower. It's often about how your appetite has gotten dysregulated for some reason, and you did not choose to have that happen.
I think it's really interesting watching the growing conversation around GLP-1 agonist
Yes.
medication for obesity. And I do hope and wonder that maybe that will start to shift some of the stigma around medications for opioid use disorder too, that as there's more cultural awareness, actually, that medication is a critical tool, and that it's not that people are lacking willpower or behaving badly or, you know, somehow flawed, but actually that there is something different, that appetite is unchecked, or that people have a health condition that needs medication, much like someone with thyroid disease, you know, can't will their thyroid to function differently. They need medication to sort of get back to normal homeostasis. And I often think back to, you know, Dr. Dole and Dr. Niswander, you know, many years ago now, back in the 1960s, discovering methadone and for as a treatment for, at that point, heroin addiction. And think of Dr. Dole as an endocrinologist with, you know, who that's a sort of this field of medicine that takes care of diabetes and thyroid disease and adrenal insufficiency, and many endocrine conditions require a quote unquote replacement medication. They require a sort of chemically similar molecule to help someone get back to a normal set point. And I think he would talk in interviews about how he really came to understand severe heroin addiction as being similar to other endocrine problems, where it's not an issue of morality or willpower. It's an issue of sort of needing a medication to help reset your set point and allow you to function normally, feel normally, and live a healthy life.
Yeah. And I mean, one of the things that like all of this comes down to is like the cultural misperception that people with addiction are like just out there seeking extra pleasure, and they're having so much fun that like you know, they would never seek help unless you hit them over the head, because it's such an amazing thing, you know. And I find that so hard to believe, because if you spend 5 minutes talking with people with addiction, it's like most of them have extremely painful lives, and you know, childhood trauma, mental illness or incipient mental illness. Like they're just trying to be okay. They're trying to like feel okay in their own body, like not trying to feel like extra special happy.
100%. I think regardless whatever reason someone was exposed to substances in the first place, I think you're totally right. By the time someone's meeting criteria for addiction, that again, compulsive use, despite bad things happening to you in your life, by definition, people are suffering. People are dealing with terrible consequences ranging from health and relationship and trauma. I think one of the unifying themes of, you know, developing addiction in the first place is pre-existing trauma, but then having and living with addiction in this country often means that you're experiencing ongoing trauma. We criminalize people who use drugs. Many people have cycled through the criminal legal system. They may have, you know, dealt with being unhoused and the trauma that can go along with that. And so this notion that people are just having fun and should knock it off, I think is completely wrong and problematic. I also think we're deeply uncomfortable with the notion of pleasure generally. And
Yes.
you know, that's a whole other conversation, because substance use exists along a spectrum, and people use all sorts of drugs and don't ever have addiction and experience pleasure from that. And that's okay too. But I think that's something that's very uncomfortable for people to talk about.
Yeah, yeah, no. And I mean, I think that when you're trying to sort of move a dialogue that has always been about these are bad people hurting other people, trying to make the argument that like pleasure is good in the midst of this always loses to, but what about the children? And so, you know, it is a hugely complicated thing, and all of these mistaken ideas really feed into each other in a terrible way. And one of the other ones that I'm thinking about here is this idea that like if you are nice to people with addiction, you are enabling them, and that enabling people with addiction to feel better or have any self-respect if they don't quit is a bad thing. If you would speak to that, that'd be great.
Yeah, well, two things. At first, I don't know if I ever told you this, but long before I met you, I fell in love with an article you wrote about the fallacy of tough love. I think in like the Baltimore Sun or something many years ago, like the early 20 teens or something. And I still turn back to that and quote that article because I think it was a beautiful article and such a good reminder of what is deeply wrong with this notion of sort of tough love, or the contrast, which is this notion of enabling. I think first, just stepping back, like if the defining feature of addiction is use despite bad things happening, and we also recognize that using substances is a powerful way of coping with stress and trauma, it actually makes no logical sense that making someone's life worse is going to help them get better. Because already of this defining hallmark that someone can't stop even though bad things are happening to them. And actually, in many ways, maybe the only thing that's helping them survive ongoing stress and trauma is continuing to use substances. Making that person's life worse, taking away their supports, taking away their kids, kicking them out of housing, sending them to prison, are not going to help that person get well. So there's just this mismatch between sort of the definition of the condition and then this idea that punishing people will help them get well. And then I think there's this idea that's just, it not only punishes people with substance use disorder, but often people's families too, who are made to feel like they're doing something bad if they love their loved one who has this health condition. This idea that if you're kind to someone, that you're enabling them or making things worse for them, rather than any other health condition where, of course, people do better when the people around them support them and love them and give them a reason to have hope for a different path forward and for a future. And so I guess the other thing that comes to mind was a great poster campaign and video campaign a few years back now by the Harm Reduction Coalition around enabling health. I don't know if you saw that, but I loved it. It sort of flipped the concept of enabling on its head. They did kind of short videos of people that folks who would say things like, I'm proud to be an enabler. I want to enable my community members not to die from overdose. I want to enable them not to get hepatitis C. This idea of like, we should all be enabling people to have the best lives they possibly can. And that actually that's the goal, partnership and, kindness and compassion, and accompanying people along that journey as they have hope for something different for themselves in the future.
Well, I always I think this must have occurred to me a few years ago, but it's like, is there any other condition where disabling people is what we want to do? It really doesn't make any sense. And I mean, and then you get into, even though the DSM got rid of the term dependence, there is this whole idea that the reason people enable people is because they are codependent and they somehow get off on keeping the addicted people sick unconsciously sometimes. So basically whatever the family member does, if they're too nice to them, then they're enabling. But if they're nagging them, they're also enabling because they are increasing their stress or something. Meanwhile, they're also told in Al-Anon and other 12-step groups that you can't control the other person, but you have to stop enabling because that's making their addiction longer. And it's it does not make any sense.
For families, I think family members who love someone don't know what to do and have often been told that they need to, be cruel to the person that they love. That I think also built in with enabling is this idea of tough love or hitting bottom. And to your point around, there's no other health condition that we would have that idea with. We would never, someone with diabetes, we wouldn't wait until someone had their leg amputated from poorly controlled diabetes to start treatment. I mean, that would be totally, completely backwards. We would want to start treatment as soon as possible and support people as early as possible and recognize that that's a much better path forward. And so again, it just shows how I think we think about addiction so differently than any other health condition.
Well, yeah. And also the mom who does everything for her child with cancer is a hero. Whereas the mom who does everything for her child with addiction is just seen as she's causing the problem. And it's just really, really ridiculous. I wanted to.
I was actually going to ask you a question about that.
Yeah, go for it.
I've talked about this before because I think family members have also seen things like the show Intervention, where they've been told that they have to sort of stage a really harsh all or nothing intervention. And I've heard you talk about actually the evidence base for why that is a problem in the past. And I wonder if you could share a little bit about that sort of confrontational therapeutic approach and why that's not a helpful style.
Sure. So, the people these days may have seen a documentary that I am in known as The Program, which was about these troubled teen programs where the whole idea is to be harsh and cruel to people in order to fix them. And that is completely backwards. You know what I mean? One of the things I always think of when you think about this is okay, if you're going to have to take a bet on who's going to recover, would you pick a person who has nothing, who is homeless, who is undereducated, who is unemployed, who has no access to resources? Or would you pick like the CEO of a major company? Like, I'm going to go with the CEO, right? It's just like addiction is a medical condition like any other. And the more resources you have, emotional and otherwise, the more likely you are to recover. And these, intervention style things, I mean, I actually did the math at one point, and hopefully I will remember this correctly, but I think I have it roughly right. I think 13% of the people in Dr. Drew's intervention show died, almost all of them by overdose. And one of the things that show was so proud of doing was, that was celebrity rehab rather than intervention. But it's the same concept, be mean to the people with addiction. But intervention, again, it's like, we're going to confront you and make you humiliated and make you feel bad about yourself. And when we look at these confrontational strategies, they increase shame, and increasing shame leads to increased craving, which leads to increased drug use. So it's really bad. And then, there's this major study of the comparing the intervention, the harsh confrontational thing, to another approach called CRAFT, which is community reinforcement and family therapy. And the idea there is just like slowly attract people into recovery and, don't create harsh consequences. I mean, don't like, give them all the money in the world to buy as much drugs as they want. But also don't be like, well, I can't, support you in any way because you're going to spend it on drugs. So it's really about helping people find their own way into getting better. And so that was twice as likely to get people into care compared to the tough love thing. And one of the interesting reasons that it was successful was that most of the family members really didn't want to do the tough thing. And that, they had gone along with it in the past, or had thought that was like the only way. And when they realized there was an alternative, they just, were like, why should I engage in cruelty? And the other like downside to these cruel and humiliating and confrontational treatments is that they teach the people who carry out these treatments that being cruel to people is good for them, and that like acts of sadism are actually kind. Now, this may be the case in certain kinky settings, and I'm not talking about that. But what I am talking about is that if you come to believe that you know exactly what's right for somebody else, and you have no humility, and you think medical paternalism is like the way to go, you will end up harming people, because if you don't listen to why people are doing what they're doing, if you don't like find out what's actually going on with them, like punishing somebody into learning is just not an effective teaching strategy.
100%. Yeah. And I often think of our friend Tracy Gardner, who, has been a part of this work in changing the narrative and giving a talk and talking about this idea of like really stepping back to ask the question of like recovery from what to what. If you haven't understood the person and their context and what they're dealing with and the trauma of their daily life and what their goals are, like the substance doesn't really matter. That becomes sort of a corollary. It's really about the underlying factors.
Yeah, and this segues nicely into the idea of harm reduction, which really is about meeting people where they are, treating people with dignity and respect, and like focusing first on stopping harm, not trying to stop the person getting high. And I'm sure you've seen patients, and maybe you have some stories around this, where somebody has, a severe, horrible trauma history, and stopping drugs is just unthinkable because they have no other coping skills. So what do you do like in a situation like that, where, you want to like help someone see that there might be an alternative?
First, harm reduction, one of the best definitions I've heard is that harm reduction is sort of radical love for another human being. I think that's a beautiful way of framing it, because at the end of the day, harm reduction is really what we should all strive for in every aspect of medicine. If you think about the first, do no harm is one of the principles of what we do. And then the other principles of sort of medical practice of respecting people's autonomy, their humanity and dignity. People who use drugs have not forfeited their human rights or their right to the very best possible healthcare or health that they can achieve. And so I think, again, at its core, amongst medical professionals, there's often this sort of cognitive dissonance that if you have learned to see addiction as an issue of bad behavior, or if people sort of willfully misbehaving, getting back to that notion of willful misconduct, then, buried in that then are going to be these notions of, well, this person doesn't care about their health, or they don't care about their community or other people because they're willfully doing this bad thing that's leading to bad outcomes. And I think that then perpetuates all of this very harm-inducing stigma. This idea of, a person who's suffering from an injection-related complication, for example, doesn't value their health or doesn't care about their health. And there's nothing you can do if they're not willing to stop using substances. And that couldn't be further from the truth. I think first, as a clinician, like when someone comes in saying, I really want to start treatment for my substance use disorder, it's pretty easy. Like it doesn't take a lot of skill to do in that case. And I think as anyone who calls himself an addiction specialist, like the real work is around the early phases. It's getting to know the human being that you're connecting with. It's understanding those unique root causes of what role substance use plays in their life and why, and if someone has pre-existing trauma, and what they like about using substances, what some of the downsides are, sort of that early understanding of the person, but also building trust and rapport. I sort of expect that anyone I'm meeting won't trust me in the beginning, because why should they? For the most part, when people come into hospitals or healthcare settings and share that they use substances, bad things happen to them. They might be treated poorly. They might, have their room searched, or they might have different sort of rules around their ability to leave their hospital room versus other patients, or even worse, they might get reported to the police or to child welfare. And so I sort of expect that the first part of that process is trying to earn someone's trust. And I think, in healthcare spaces, that's often starting with understanding like what are their subjective needs in this moment, and then being willing to actually meet them to the best of my ability. And often that's something like clothes or a warm blanket or some food or some pain relief because they're in agony, or withdrawal management. It's not sort of going through a whole diagnostic assessment and trying to talk about treatment, because that's not where someone is in that moment. And it also is completely counterproductive. So I think starting from that, really base of building relationship, building engagement, engaging around whatever need is most pressing to the human being in the moment, and then working from there is how sort of I would start in that type of assessment.
Yeah. And I mean, there used to be this idea in the field that like, if somebody has trauma, like you should not do anything about it, because like, maybe you're going to re-traumatize them, or it's irrelevant or whatever. But the approach has either been to completely ignore this and assume that nobody could actually work on the trauma until they give up the drugs. And in harm reduction, we see all the time that it's the opposite, that like until people have figured out what is going on with that trauma, sometimes they cannot quit the drugs.
And if they're still in a situation where they're experiencing ongoing trauma, the idea of giving up substance use is going to be really impossible. I mean, I think of what some of my patients endure, and I don't think I could endure it sober. Think about living on the street, being at risk of getting victimized or abused or exploited, feeling isolated or alone or a lack of support. Those are really challenging things. And so, of course, people are going to use substances in those experiences. I think, part of the challenge with what you're describing too is this idea that has long separated out sort of treating people's other mental health conditions and treating their addiction, that those two things have to be separate. And then in fact, you can't even diagnose many, some psychiatrists will say you can't even diagnose many types of non-substance use disorder, psychiatric illness until someone has been abstinent, because until then they'll sort of say, well, it could be a substance-induced mood disorder or substance-induced psychosis, et cetera. But I think that misunderstands the human being and their experience. If you're experiencing active paranoia or active trauma, you're not going to be able to stop using substances, and they don't experience those things as separate. And so really thinking about how do we holistically address the needs of the human being in front of you, rather than these sort of siloed buckets that have long existed in medical practice.
Yeah. I mean, the separation from mental health is so ridiculous, because most people with addiction are self-medicating to some extent. You know, and you know, the idea, like, again, goes back to the abusing idea, because it's just like, oh, these people were just like happy until they stupidly tried something. And then they, like, you know, became zombies who are motivated only by the substance. And like, when you look at like who gets addicted, it just isn't that way. You know, I mean, one of the misconceptions that I see a lot is this idea that, you know, when opioid prescribing rose, like the people who got addicted were like going to their doctor, they were just like innocently going about their lives, and they got this prescription for, you know, minor backache, and suddenly they're robbing drugstores. And this is just not how addiction typically happens. I am sure there are some rare, obscure cases where a person meets a substance that is so perfect for their physiology that they give up their extremely happy, perfectly functional life for that substance. In the real world, what I see in, you know, talking to people, is just that, you know, somebody feels socially isolated and miserable, and they find something that increases their ability to feel connected, and then they continue to chase that.
No, and I think, and you've talked about this, and the data has shown this, that even if you look back to those early days of the prescription opioid crisis, where the narrative was often that the sort of innocent white victim, and I'll say that's another important piece of this, that part of this sort of mythology was the whitewashing of the overdose crisis, that there was often, it's a story of like a high school athlete who got prescribed, you know, Vicodin after shoulder surgery, and then all of a sudden he has developed severe opioid use disorder, when in fact what the data shows was that there was excess pills in the community, and people sort of using excess pills recreationally, often who had already been using other types of substances, that developed opioid use disorder, not the kind of de novo iatrogenic addiction in the context of prescribing.
Yeah, well, and I mean, oftentimes that the innocent high school athlete had been doing cocaine and MDMA and far beyond just a little bit of like, they got a prescription themselves or their friend, you know, 80% of the time it's their friend or family member or whatever. And then, you know, they end up in trouble. I mean, I think like one of the things that so many people don't realize is that like most addictions start in the teens or 20s. And that like, if you are in your 40s and 50s and you haven't previously had an addiction, your odds of having one are really quite low. And this is, of course, what the drug companies like preyed on to like over market the substances, but it doesn't make it any less true.
Yeah, no, totally. And I think, you know, buried in there too is this idea of needing to assign culpability to people, that somehow this, you know, often fairy tale notion of the, you know, person who had no pre-existing substance use disorder, who was prescribed this medication by either an unwitting or bad doctor and sort of bad pharmaceutical company, then the person, you know, at no fault of their own develops addiction. And somehow we can feel collectively, we society can feel empathy for that person with substance use disorder, but the person who has early childhood trauma and, as you pointed out, feels uncomfortable in their own skin and finds comfort in using recreational substances and then develops a substance use disorder, somehow they're to be blamed, and we don't have empathy for sort of that path. And I think it's just this odd notion of needing to blame people for their health conditions, or to have this certain archetype that people can somehow feel sympathy for, as opposed to other pathways.
And I mean, I do think that like a lot of this comes from, we really want to separate ourselves from people with addiction, because I guess, and I think this is true, that everybody, or at least most people, have a fundamental fear of losing control over their life. And when you see this happen to someone else, you want to distance yourself, whether it's pain, or they have pain or addiction, or they're poor, or whatever it is. You want to be like, well, that could never happen to me because I'm a good person. And like, that's a terrible way to think, but it's sort of a lot in our psychology. Like when you see like something horrible happening to someone else, there's this, like, they call it the just world thing in the just world hypothesis in psychology. And it's this idea that like, bad things happen to people who deserve them. Good things happen to people who deserve them. Therefore, the rich deserve to be rich. The poor deserve to be poor. And we need to rationalize the heck out of anything that violates that. And I really feel like this plays into a lot of our stereotypes and misguided narratives around addiction, from the like, we want to have the innocent pain patient story, as opposed to the guilty, like, crack smoking story, to just the like, I don't want to look at the fact that like I might be at risk because that makes me a bad person.
Yeah, no, I think totally. I think there's fear at the core of that, and then this othering that happens. You create this gap between those people and me, myself, and my people, and then of course that worsens any possibility of empathy and understanding, and perpetuates all the stigma. And I think with, you brought up the crack example, and we've touched on this a little bit, but racism then intersects with all of that. So when communities of color have been impacted by drug use and overdose, there's been the war on drugs and mandatory minimum sentencing and mass incarceration. And then when the perception was this, perhaps fairy tale notion of the, innocent white victim, then all of a sudden we're talking about sort of public health responses and health responses. Not that we've gotten that right, nor are we truly enacting a public health response, but even the change in that sort of conversation, I think, has had its roots in some of the racism that's been intertwined with different societal reactions.
Yeah, absolutely. And I think I'm glad you brought up the sort of war on drugs versus the like public health response, because I feel like right now there's enormous pressure to like go back gung ho on the war on drugs, and to just be like, harm reduction is bad, it's enabling people, it's causing like, needles on the street, or just, homelessness, or, that all these liberal policies are just bad because they haven't fixed everything yet. And I always want to scream when I hear that stuff. It's just like, well, we haven't actually ended the drug war. Like, we haven't actually, put the money that we put into enforcement into treatment. And when we tried to do that very briefly in Oregon, before they could even roll the treatment out, they rolled back the decriminalization.
Completely. I think we expect these like magic fixes and immediate results. And when things haven't overnight changed, it took us 100 years to get here, right? But if things don't change overnight, then we call it a failure. But also there's multiple different complex problems happening. And, changing drug policy is not going to affect affordable housing or homelessness. The only thing that solves homelessness is giving people houses. And so there's often this idea of like a minor change in drug policy. And then when people continue to have nowhere to live, and there's sort of visible poverty and trauma and homelessness, as well as drug use, then the drug policy change is declared a failure. But we haven't done anything to address those other factors. And so I think the other piece buried in there is like, what actually is intervention? What's the measurement of success? Like, how will we know if it's successful? And then did we actually give it enough time, support, resource, funding to actually get to the place of having a positive impact?
Well, yeah, no. And I mean, it's always like, drugs are just so convenient, because you can say, oh, people are homeless because they use drugs. People are poor because they use drugs. If we just slap them into shape, then they will be, self-sufficient and not dependent. They will go out and like, become rich people or something. And the, it's just like, it just serves as such a symbolic way to like divert policy and divert our thinking around these really complicated issues around, like housing, not a simple problem. Like, is it more likely that someone with addiction is going to become unhoused? Yes, obviously. Does that mean everyone who's homeless is addicted? Absolutely not. In fact, most of them are not. Also, if you are homeless and, you are in, traumatic chaos, like, why wouldn't you use drugs at that point?
And I think at the core is, again, you're alluding to this, but this notion of like the pull yourself up by your own bootstraps American mantra of like, well, people just need to work harder and they need to slap themselves into shape and knock it off, instead of recognizing like actually the many factors that are working against that. And you take someone who does, let's say someone engages in medications for opioid use disorder and they're not using substances and they're in remission and they're still homeless. It's really hard to find a job, to find housing, for anyone, but particularly someone who's dealing with all of that. And it's very hard to stay engaged in treatment if you have no safe place to live. And so I think, again, broadening out to think about the complete picture of what people are dealing with and these complex social problems and how do we address things in a more holistic manner is really critical.
Yeah. And I mean, I think like the pandemic and just like rising inequality in general has really, shattered our social connections and really made it difficult for us to, depend on each other appropriately. Like interdependence is like the human, condition. And we all we're wired socially from like the time we're born to rely on other human beings for stress relief. Like a baby cannot relieve its stress. Like they need their, parent or caregiver, and they need one or two of them who are completely devoted to that baby, because otherwise there's going to be serious trouble. And so we're not as dependent on other people for social regulation as babies are, but that doesn't mean we're not dependent.
And nor is that a bad thing. I think it's it's such a Western and particularly American cultural thing to sort of prize independence above all things. And, just on the motherhood front, like as a mom of 3 little kids, I always find it so fascinating that the first question anyone asks you is is your baby sleeping through the night? And it's no, they're a newborn. They're not supposed to sleep through the night. They're supposed to need their parent for every function and to wake up to feed. And, any other culture or any other mammal, we would expect that. But somehow in the US, our prime example of success is how independent, how quickly are human beings. And the reality is we're all dependent, and that's a beautiful thing. Social connection is at the core of so much of our experience in humanity, and certainly at the core of helping people get well and thinking about recovery.
Yeah, no, I mean, to me, one of the great misunderstandings that we have as a culture is that we think that you need to learn to love yourself before you can love other people. And no, the way you learn to love in general is by being loved. And if you didn't get enough of that at the right time, during your childhood, that's going to be a really hard task. But going away and being a hermit until you suddenly love yourself, or in some kind of individual therapy until that is just ridiculous. It is not, human beings need each other. And, I say this very much as a person who's on the autism spectrum, is probably on the lower end of the being able to deal with people all the time spectrum. But I still recognize that, our highest joys and our most important achievements in life are really about, the way we connect with other people. And I think everybody fundamentally realizes that, we still want to chase the pretty nice things and, vacations and, whatever. But the reality is that our interdependence is one of our greatest strengths. And we forget this around addiction. We just demonize the need, and we demonize the way people are just trying to get by. And I don't know, it's a really hard thing to get at. And with this, trying to change the narrative thing, it sort of, we have to confront some of the most difficult issues in the way Americans and we see each other in general.
That's so true. And getting back, to the notion of dependence and relationship and where we started, I think, again, this idea that dependence, codependence, or enabling is a bad thing, instead of seeing, again, one of the greatest gifts we can give to people is to love them as they are learning to love themselves, or to hold a mirror up to show them the sort of beautiful, resilient self that other people see when they don't feel that in that moment. And I often think of that, in addiction medicine, that by the time I'm seeing someone, they've often been told that they're bad, they're a failure, they're never going to get well, that they've done something terrible. And I think one of the most powerful things we can do early on is to just sort of tell someone we believe in them and that we care about them and they have value as a human being, and to help them begin to feel, again, a sense of self-efficacy, that they can do this, that they might want to do this, that their life might get better in some way if they made changes to their substance use. And that is not a bad thing. That's not a codependent thing. That's not an enabling thing. That is the power of relationship and human connection, that I think is at its core of really, whether you want to call it harm reduction or treatment or recovery, really at the core of all of that is human connection and kindness and respecting people's dignity and autonomy.
Yeah. And I mean that when we think well of other people, they tend to think better of themselves. And, obviously there can be all kinds of bad people out there as well. But for the most part, if we do engage and if we see people as being well-intentioned, they start to see themselves that way more. And if you can sort of inspire people to realize that they're worth it, and that, not that like abstinence is the greatest thing in the world or anything like that, but just more that like what they're worth is having a life that they want, that makes them as comfortable and give them as much meaning and purpose and love as possible. And drugs can get in the way of that. They always do when you are addicted. So trying to like, instead of, the person, it's also hard for people to see that the people with addiction see the drug as a solution, not the problem. And you're trying to take away the solution. And instead of like being like, no, we don't want to take away the solution. We want to find a solution that works for you, that actually works for you, that is not getting in your own way. And it's not about like, I mean, I think often this happens with parents and kids, like the kids saying, oh, the parent doesn't want me to have any fun. They want to like just make me conform or like, put me on this stuff that makes me feel terrible. Whereas like the parent just wants the kid to be okay. And they see them taking these risks and freak out. And, and instead, if you can, ally with the child and ally with the fact that like, they just want to feel okay too. Let's find together the best way for that to happen that is going to minimize harm.
I'm a very visual person. I often sort of visualize, the substance is filling a huge role in someone's life. It's literally like taking up space and feels like a solution to your point. And so then the work becomes not just removing that and leaving a gaping hole in someone's, life and experience, but figuring out what are the other things that are going to fill that in, that are going to allow people to live their best life and whatever that means to them.
Yeah, no. And I think, it's really important for people to know, and this is another one of these narratives, and this is probably the last one we can get to, but most people recover. If you can speak to that and the data on that, that would be great.
Yeah, I've started, I think a lot about the language piece too, and sort of what are the right terms, because chronic disease, I think sometimes implies this sort of recalcitrant nature, or, that something's broken in someone's brain, as you've written about. And so I've started talking about addiction as a treatable, good prognosis health condition, because I think it is a health condition. It's incredibly treatable, and it actually has a very good prognosis, which is not, I think, what people have in their mind when they hear, someone's using fentanyl. People are not thinking like, wow, that's a great prognosis health condition, but it actually is. Like, I treat I also do general internal medicine, and there are very few health conditions like diabetes or, heart disease or lung disease that have as good of a prognosis as addiction does, that most people will get well and treatment is incredibly effective. And although there are many pathways to treatment, when we're talking about opioid use disorder, the treatment success rates with medication are astoundingly high. And so to me, it's really a failure of how do we get people access to the range of services and care and treatments that we know are so effective, and support people in this treatable, good prognosis health condition.
Yeah, no, I mean, and I think, the fact that most people think that most people die addicted, or just, whether they're 29 or 70, that this just never gets better. It leads to a lot of hopelessness. And, it can certainly take some people a long time to get better. And the severity of the addiction does play a role in that. But if we can keep people alive, which is harder in the age of fentanyl, but if we can do that, then yes, absolutely. And I think we need to let more people know that, that people do recover, and that like the idea that this is hopeless is really not true.
I actually was just giving a talk for another paper of yours, but you wrote a great piece in the Times that addiction doesn't always last a lifetime. And I think that's part of changing the narrative, is sharing the story of people who are living vibrant lives in recovery, whatever that means to them, however they define that. But that for most people, this again is a treatable, good prognosis condition.
Yeah, just see, I mean, it's always so inspiring to talk to people in recovery, I find, across the spectrum, because the stories people have are amazing. And sometimes you hear this and you're like, wow, I can't believe you survived that, but it is remarkable. And I just always think about like when people are just like, oh, let them die or whatever, the amount of like talent and kindness and just good people that we're just willing to throw away. It's just really sad.
I think the grit and resilience and, to your point, kindness and talent of people who've survived and are living with substance use disorder is tremendous.
Well, thanks. I think this is probably a good place to stop?
I think so.
That was really fun.
That was great. We could have talked for another hour.